We are now going to go through protocols 25, 26, 27, and 28, but we're going to take it muscle by muscle, and we're going to look at the muscle, its referred pain, then we'll evaluate length, strength, palpation, and treatment. So that's it. Each muscle, referred pain, length, strength, palpation, and treatment. That's what you need to do as a trigger point therapist. For each of these muscles, there's a specific pattern of pain. There is a normal range of length and shortening. There is a normal response to a strength test, and there is a normal quality to the feel with your hands called palpation, a palpatory quality. And you should be able to evaluate all those and treat it to correct anything that's not doing, it's not the way it should be. Okay. All right, we're going to get started. Sharon, what's our first muscles?
Well, we're going to treat the rectus femoris, and we're going to do two tests for the rectus femoris right here.
Okay,
so here's where it's attaching onto the pelvis, and then here's where it's attaching onto the tibia. So it attaches onto the anterior inferior iliac spine, and then down here to the tibia. And of course,
baseball pain, right?
That pain in the kneecap right there. Really bad kneecap pain, deep in the kneecap. And it's L2 to L4 and it's nerve roots. And it crosses two joints. So that's why we're going to do the Thomas test. And you could also do the supine.
Prone.
Well, we're going to do the prone one, yes.
Yeah, we'll do the prone. Prone knee to buttocks.
That's what we're going to do, yeah. So because it crosses two joints.
Yeah, you have to get two joints to flex to test this range of motion.
Okay, so this is Travell and Simon's book, volume 2. And we're on page 250. And this is a well-used book here, you can see.
Yeah. If you have these charts and you want to know which test we're doing, we are doing the... They call it the hip flexors test, but it's called the Thomas test. Okay, where they lean back. We're evaluating this should be below 90, below the midline, and this should be hanging straight up and down and easily bend that way. It shouldn't be flexed out or the hip hiked up. And then we'll be doing the heel to buttocks, but we'll be doing lying on the stomach. That's the way you can flex the hip. So this would test the vastus muscles, but it doesn't test the rectus because the rectus crosses the hip. So we're doing this lying prone. So this test on your stomach, 33 on the stomach, and 31, the Thomas test. Here we go.
Okay, so here we're going to do the Thomas test. So we're going to sit right on the edge of the table, and you're going to put your hand underneath your knee there, and then you're going to assist them and come on down. And so you're going to see how does the knee fall. So this would be, she doesn't have trouble with the psoas, but she does have trouble with the rectus femoris. This is like
it should be hanging down at 90 loose.
Very positive sign that she's got real bad trouble with the rectus femoris. Okay, let's assist you getting up.
Try the other one.
Let's try the other one. So significant trouble there. Okay, so we're going to come on back. Okay, and here again, this is so it should be hanging straight down like this.
Are you sure you have a knee?
No.
Is there a joint there? Because it doesn't seem to be bending.
Okay, so that's that one. Can we check you, Kirk? Can you come on up here?
All right, get it over.
Okay, so real close to the edge, closer to the edge. Okay, so you're going to go underneath one knee. Okay, so you go ahead and you're going to take this back, and I'm going to help you. Okay, so
and so that's better.
We have two. So this one here, his rectus is okay, but this one's showing that his vastus lateralis and/or tensor fasciolata might be pulling
or
off to the
even
side.
a little bit.
It's
pulling off to the side.
To the side,
so you see how it's pulling. Yeah. Sharon, can you move a little bit?
Oh, sorry. Yeah.
So see how it's pulling to the side? I didn't see that from the other angle. Yeah. Yes, that's right. Exactly. Wow, really cool. Okay, this test shows a ton of stuff.
Okay, so we're gonna look on the other side.
And it might have been a little bit of psoas. Might have been a little psoas tight because the hip was up a little bit.
Okay, so let's go ahead and take it back.
We were asked, is it necessary to have them sit up between legs? I think it is, isn't it? To switch legs?
Yeah.
Yeah, it's usually pretty good.
Okay, so here it shows us his rectus is good, but on this side, but it's a little bit tight on his TFL and his vastus lateralis.
Yeah.
Okay. Yeah. So let's go on and take you up.
Excellent. And Kirk was recently a celebrity, so he's got to wear sunglasses now.
That's right.
Now he had Yeah, eye procedure, so he
Okay,
needs to
so
have glasses
Stephanie will
on.
do it real quick. Go ahead, real close. Let's go ahead and get underneath. Let's come on back. Okay, so here, Stephanie shows that she doesn't have rectus femoris dysfunction, and she doesn't have vastus lateralis or TFL.
Yeah. And also,
Or psoas.
Yeah, exactly. Since
She's
this drops
perfect.
below the
Stephanie's
midline,
perfect.
that psoas is good. Well, now wait a second. Just to stress the point, though,
Oh.
range of motion doesn't tell you
No.
that there's not a problem.
No,
It
that's
says
true.
one indicator is good
That's
because the ultimate indicator, which never fails, is palpation.
That's right.
Palpation is the rule. The golden rule is it
Okay,
must
so
be
this one-
smooth.
This one
Oh,
here
well,
shows
here we
that
go.
she has dysfunction in her rectus.
So
Okay.
rectus only on one side?
Yeah, rectus on the right.
Cool.
Okay, thank you, Stephanie. Okay,
Excellent.
so let's take a look at
The prone, the other way.
Let's look at the prone. So let's come on over this way. So you're gonna go ahead and lay on your tummy and put your head up here.
Okay. If you did this on your back, you'd be testing the rectus, or the vastus groups, but not the rectus.
Okay, so here we're gonna measure from the heel to the seat.
Yep.
So from her shoe to the seat.
Do you want to take my shoes off?
No, it's fine.
Yeah. So this is like 5 inches.
Yeah.
And so the pressure you give is a light pressure. So you're just putting it. You just go to where it stops
Yeah.
lightly.
Just the end range.
Yeah.
You know. It's
And
not.
this
You're
is-
not forcing it.
Yeah. So I see 6 inches.
6
And
inches.
this is the International Mild Pain Society gave this to me.
Oh. That's
Okay. And we'll do this side. And let's see from the shoe. And this is about 7 inches, between 6 and 7 inches. Okay.
great.
So we'll try again without the
Passing
without the
is
shoe.
that should
The
loosely
heel should touch the seat.
should touch the seat
The heel should
loosely
touch
and
the seat.
easily.
Want
Yeah.
me to take my shoes off?
Well, I already did the test.
Oh, okay, all right.
Okay. Okay. All right.
With or
Go
without
ahead.
shoes?
Better without the shoe. Yeah.
Better without the shoes.
Because I'm measuring the shoe.
Yeah, I guess my answer to you, questioner, is that just the palpation is the ultimate rule. You can have, you can pass tests even while having dysfunction. It's very true.
So here, again, I'm gonna like relax.
Yeah. No,
relax,
Jeff, you're right.
Breathe,
Absolutely,
breathe,
you can.
relax. Okay, so here we're gonna test here. So here we're gonna go, and that's about 6 inches. And let your hips fall down. And again. Oh, good. Thanks. Okay, so here you go. So we're going to go from the heel to the seat. So you're going to go from the heel to the sit bone. So go ahead, and that's about 7 inches.
Now, of course, there's no ruling out the vastus in this test either. I mean, the vastus
no.
are included. So,
Yeah, all of them.
Yeah.
And about 7.5 inches here.
Yeah.
Okay, so remember, 7 inches, 7.5 inches, okay?
okay. Should we do one more?
Okay, one more. Okay.
One of us had better pass. We gotta get one of us passing. This is embarrassing.
Woo!
Yeah, this is good.
Okay, so here, Stephanie from her is about
Couple or
that's
so.
2 inches.
Yeah.
2 inches on your left, okay. And on this side, oh, it's just like 1 inch here, and that's 1 inch.
Okay.
2 and 1.
Okay, great.
Making us look bad.
Okay, so we did the stretch test for that.
Okay, you guys want to see strength?
We're gonna do a strength test.
Strength
so I'm
rectus
gonna
femoris.
hold on
You
to
hold
the
this.
camera. Okay.
Here, I'll just do. Steph, would you mind? Okay.
Lay down.
Face up, please. Okay. So when we do the rectus, since it crosses both joints, we'll have the knee bent and the hip bent to 90. Okay, hold this, please. I'm going to have her push into me first. Remember, this is called conscious engagement. She pushes first. Push into my hand, please. And then I add 1, 2, 3, 4 increments of increased pressure. And that's a positive strength
Pass.
test. It's a pass. It doesn't mean she lifts 200 pounds or 300 pounds or 10 pounds. What it means is that the muscle is actively engaging. There's no inhibition stopping the muscle from firing. Okay, that's what we're doing. It should be called muscle facilitation test, but we all call it strength test, right? Muscle test. All right, keep this here, please. Push into my hand, and I'm going to add 1,
Hi, Judy.
2, 3, 4. Good. That's it. All right. Thank you very much. Those are both passes.
Pass.
Okay. So we said muscle, we said referred pain, length, strength, palpation, and treatment.
Great.
So-
Here we go.
Let's
Okay,
palpate
so-
and treat one of these babies.
Okay, come on over, Camille.
Now you want to see some fails.
Well,
Okay, so you're gonna go ahead and lay down on your back.
quads, probably something everybody has treated before. But how would Sharon treat it? How would a master body worker treat it?
Well, we treat it different ways.
Yeah.
But so sometimes we put a little heat on it, often like we do, and we look at the kneecap. Oh,
Okay.
the kneecap looks good. The kneecap's coming down. That's good. But remember, we want to look. We start at the inferior iliac spine. So let's find the superior, inferior. Then we find where it attaches onto the tibia. So here we're going to go straight down the middle,
Uh-huh.
and when we're treating it. Now, tell us. Could you tell us what happened to you? You
Okay, I had a car accident at the end of June and my knees hit the dashboard.
Yes.
Ooh,
So
sorry.
there's pain everywhere, especially the left.
So
Oh,
not on
sorry.
the outside of the knee, but the back of the knee, the outside, the
Back
inside.
of the knee,
inside of the knee?
quads, the hamstrings, under the kneecap, and the medial knee.
Okay.
Ooh,
So
sorry.
then
More on left than the right. but
more on the
both.
left than the right. Okay.
Okay.
So one way we treat it is have them lay just like this, and we could go like this, and find the top part of the muscle here, the superior part, and we're going to go straight in like we just did. So first we just touch. So we just touch, and then as soon as we feel the resistance, we go down slowly, and then we stop as soon as we feel the resistance of the taut bands.
Okay.
And then how's that feel?
It's fine.
So we'll go down a little bit more, especially since she says fine. Okay, what do you think there?
I feel that.
She feels that. So we're looking for a tight spot, and we're looking for a little bit of painful tight spot. Okay.
I think maybe before you treat the left, I might just test it because
Sure.
it might be good to see what a week looks like.
And then I feel
It
more.
sounds like it probably is going to test weak because of
So-
our reaction to the injury.
So usually, if you about a few fingers, so if you put your finger right here on the inferior iliac spine, and you go down a few fingers, about right there is
That's
where the most painful, most likely to cause under the deep knee pain, right here.
So there could be trigger points throughout the entire muscle.
That's right.
The famous one, you could say, the one that causes
The
the,
most
referred
famous
pain, is often marked by a bigger X on the charts, and that's the famous one. They usually not name them like 1 or TP1.
Now,
So,
So-
TP1 is here, and it
that's right.
causes
Right.
that
Right.
pain right
So,
there.
after you're in practice for how long do you decide to get a high-low table? What do you say, Camille?
I think I waited 10 years.
She waited 10 years. So, but
Well, they weren't around when they started.
Yeah,
Yes,
that's
right.
true.
we would have had to use a chiropractic table
yeah.
or some other kind of table. So here we're gonna put our elbow right there, and we just touch and then feel the resistance. So right there, I start to feel the resistance, and I'm gonna of the taut bands, and we're gonna come down, and we're displacing some of those painful sensitizing chemicals.
Yeah.
So substance P, tumor necrosis alpha, interleukin 1 and 6.
And some feel-good chemicals like serotonin.
That's right, serotonin, and
Yeah.
it has low pH.
And
Oh, that one I feel more.
and we're also causing a micro stretch.
That's right.
We are stretching the small myotactic units that cannot be done with a normal gross stretch. This has to be done with compression. Compression is a form of stretch.
Micro stretching,
Yes,
and then we'll macro stretch.
yes.
Often I hold the kneecap down
Hold the kneecap down.
so that I'm stretching it down. Because remember, high riding patella is the most likely cause of knee pain and precursor to a lot of knee pain and dysfunction.
Uh-huh. Leslie asked about pulling the muscle up while compressing. I'm not
That'd
sure
be
what
fine
that was.
too.
That
You
could
can
be
do
fine,
that
yeah.
too. And we'll come all the way down to right where the kneecap.
The good news is that the muscle wants to feel better, so it will respond, positively. Even if you're a bit of a hack in the beginning, it still wants to get better. So, you're doing the right stuff here, so it's going to respond.
Okay, so now you want to see Is your kneecap coming down? Oh, it's coming down. That kneecap's coming down, so that's good. So you want to, if it doesn't go this way, often the vastus is limiting it. If it doesn't go that way, the vastus medialis is limiting it. And if it doesn't come down this way, rectus or intermedius. Okay, so we just went straight down the center, but something that works really well is to also treat it while you're stretching it.
I see.
So why don't we do this one on the stretch?
Okay.
So why don't we go ahead and do the strength test on it?
Yeah,
And-
we've seen that this is weak before, so I thought I might as well just show you. So we do the exact same thing, 90 and 90. Right, here we go, 90 and 90. Camille, you push into my hand first, push, then I add 1, 2, and then by the time I start adding 3 increments of pressure, the muscle, it gives, which means that the nervous system is saying, I don't want to contract this muscle. And so we need to go to the, Golgi tendon organs, maybe at the origin and insertion, or maybe the spindle cells all throughout the belly of the muscle, or even just trigger points that are sending ouchie signals to the spinal cord that's shutting the muscle off. So we'll treat the muscle and see if the nervous system says, oh, okay, fine then. All right, we want
Okay.
the nervous system to say, yes, contract.
All right, so we're going to take, now this time, Camille, we're going to treat it while we're stretching it. So you can scoot all the way down to the end of the table over here. Coming down. You can put your foot on there.
There you go.
You get really close to the edge.
A master body worker would remember to use heat. A master body worker would use elbows instead of killing their hands. And a master body worker would also treat on the stretch. So those are 3 things.
Okay, so I'm going to have you go ahead and lean backwards, see if we can get you comfortable. What do you think?
That's okay.
Adequate? Sure. Okay, good. Okay, so let's make it, let's take the table down just a hair.
So you see how Sharon is heating up the next part of the body while she's working on one part. That's frequent. I see her doing that all the time.
That's common. Okay, so here we're going to take a look at the rectus here. So we're going to go right. Oh, now we put it on the stretch, and boy, you feel the top bands stick out now.
Yeah.
Now we feel.
Pop right out at you.
Woo! They're popping right out. Okay. Okay. And also, I can feel the adductor longus and brevis are sticking out as well. So we're going to go ahead and treat it while we're stretching it. So I'm going to feel the superior ankle, the superior iliac spine. Then go to the inferior one right there. So we'll start right at the attachment onto the bone.
Yeah, that's where the Golgi tendon organs, or the GTOs, are. They're the ones that shut a muscle off if there's too much rapid stretch, like maybe a stretch from being, hitting a dashboard or something like
So you
that.
can, yeah, something like that.
Something like that.
Something like that.
I don't
Okay.
recommend that.
Yeah.
So here I can really feel some taut bands
Yes,
here with
I
my
know,
elbow.
that's
So my
fine.
elbow is evaluating.
Camille's feet are resting on something high enough so that the 90-90 is achieved there. That
So
90.
you can really feel the taut bands sticking out. So you know which ones are dysfunctional.
Once she gets off the tendon, well, then there are spindle cells that could cause the muscle not to fire, and then any muscle, any nerve in the muscle that is relaying pain information will cause muscle inhibition. In fact, a neat trick is if you've got someone's muscle, and I taught my son this. This is a funny story. My son wanted to beat everybody at arm wrestling, so I taught him how to pinch the other guy's bicep really hard, and that pain response causes it to neurologically shut off for about 12 to 20 seconds.
So is that fair?
Well, well, no, I told him he wasn't allowed to win money that way.
Okay. He can just show off now.
Yeah. But he did it. So he pretended to check the other guy's bicep out, and he would pinch it, go, ooh, nice bicep, and he'd pinch it hard, and the guy go, ow.
Oh,
And then,
that was a good
all
one.
right, go. And then that pain signal inhibits the muscle. So muscle contraction.
So give it a nice stretch
There we go.
and a little massage. And I feel a lot of tension here closer
Yes.
to the knee.
Yes.
So I'm just going to come look at that a little bit more. So I can feel the taut bands sticking out right here and right above the knee, and both the rectus, the vastus lateralis, and the medialis. So I'm going to take a look, treat all of them at the same time.
With Camille, we had found that the nerve roots were quite in need of treatment as well.
Let's
so.
treat those also with her laying
1, 2.
supine. Yeah.
Okay, all right.
I'll do that.
All right.
And let's come down let's take a look at the knee itself here.
Yeah, Sharon is great at understanding and teaching that ligaments and tendons are very rich in nerve tissue too. They send signals. Even the periosteum around the bone is rich in nerves. Oh my gosh. So your brain is receiving so much, your spinal cord and brain are receiving so much information from the periosteum, the little saran wrap that covers all bones. So it's really important. She fixed a very bad problem in my mid-back by working on the periosteum in my thoracic vertebra, which I couldn't even believe it was, you know, okay to treat it. I mean, pushing on bone doesn't sound normal, but it literally fixed it. It was so excruciating, and eventually it just gave in and stopped being excruciating, and literally I never got the pain back. Where I'd had repeated treatments over and over and over, which temporarily helped it, but no one had gone to the part that hurt the most and said, "You should not be screaming." Silence. She silenced the angry nerves in my periosteum.
So one of my friends I hadn't seen in 60 years, what she said, she says, well, I met my friend after 60 years, and I had pain when I sat down, and then Sharon reached around behind me and looked at my spine, and she said, after many years of going to PT, she failed PT many times. One pressing on her back there fixed her back pain and her hip pain.
Yeah.
And all I did was reach around there and look at that spinal root.
And you know, it's not that they don't get attention, these parts of the body. A lot of people do get body work done, but it's that going to the areas where the nerves are screaming and pushing into that screaming area and silencing it and showing it how to function. Most people are they don't know that it's okay to do that. They're not brave enough or haven't been encouraged enough to have the confidence to do it. So the other and probably most important factor that a master body worker has is confidence. Yeah, and core, absolutely. Confidence to go and work on the area, to believe in the body. That's just a heating pad, yeah. To believe that the body can heal, the confidence to believe it can heal, the confidence to know that everything you're doing can only help, the confidence to coach the patient through things that may be painful in order to get to the other side and regain function. It's a lot of the game is confidence. Confidence to make mistakes and be all right with that, and know that that's just more information. Mistakes are as an evaluation tool. It's all right. What modality is this? I don't know. Petrissage.
Okay, so here we're going to go ahead and treat with, so we like to use all kinds of spa techniques as well as compression. So I like to use a lot of different spa techniques as well as and massage techniques along with the compression.
Yeah.
So here I'm going to go ahead and look at the patella tendon again. So here I'm finding the patella and then finding the tibia, and I'm going to work right there, right on the tendon.
Yeah, right. And again, not a place that's very comfortable to push on, and maybe not something most people would go to, but it's rich in nerves, guys. There is nerves in here. Those nerves are controlling. You know, people ask, okay, chiropractors say that spine controls all disease because, you know, the nerves go to all parts of the body. But then the question was asked, well, what affects the nerves? And the answer is
the muscles.
Environment, feedback from all the nerves that are richly endowed in your muscles and ligaments and tendons and periosteum. The nervous system isn't controlling like a master over a slave. It's actually taking orders from the peripheral tissues, sending information in. So, you know.
So let's take a look at the nerve root for the rectus femoris. So let's look at L2, L3, L4. Okay.
Yeah.
So
great.
So for that, I'm gonna bend her knee. I'm gonna come underneath. I'm gonna feel L5. I'm going up to L4 right there. So I'm gonna find the spine, spinous process, and then I'm find the transverse, and go right between, press towards the spinous process.
Are you using knuckles or are you
No,
using
I'm using
fingers?
my fingers.
Fingers,
so I'm
okay.
liking, those of you who have taken Jin Shin Do, this is a Jin Shin Do technique where you're pressing up and into the tissue like that.
Great, okay.
So we're going up like that. So then I'm just noticing how easy it is for us to move. So here
you guys are too funny.
Okay, so here we go. So I'm pressing right in. I'm stretching it a little bit while I'm pressing into it.
Yeah.
And I'm coming down here to L5, L4, L3, L2. Okay, push towards me and relax. And push towards me. Good. Okay, let's take a look at the other side.
Does that feel good?
Mm-hmm.
Oh yeah.
Okay, let's take a look at this side. Again, I'll start at L5.
If she's incorporating range of motion here, she's got the rectus stretching and flexing, over one joint. It's shortening, one joint is lengthening, but she's getting movement in there while she's working on the nerve roots that feed all the muscles and joints in that area.
So this would be L4, L3, and L2.
Yeah. Those of you that get this done, you know that this is some of the best stuff in life right here.
Okay, good. Okay, so if I could have you scoot back onto on the table. I can help you if you like. Okay, scoot. So if you could go scoot back up. Yeah. Okay, go ahead and lay on your tummy.
Yeah, laughing at yourself is one of my main therapies, actually.
Take this off.
Sharon laughs all the time.
Oh, I do.
Yes, we are in the laminar groove, exactly. In the
Yes,
paraspinals.
correct.
Yes, she's coming up and she's going toward the spinous process, and then she's going out toward the transverse process, then in toward the spinous and out towards the transverse.
So in this position here, so this is another way to do it. So here's L5, L4, L2. So again, here's the spine, and there's the transverse, and we're going to get right in between. So we're going to go like this, put our little pointy part of our elbow there. We're going to press in, go towards the spinous process, then towards the transverse process. How's that feel?
Fine.
What?
I feel a little bit, but
feel a little bit.
okay.
Fine is not that descriptive.
It's okay. We like what you said.
All right.
It feels
Like
good.
fine.
Feels good. Okay.
We
So
like fine. Okay, and then we'll go on the other side. So here's our L5, 4, 3, 2, right there. So let's come right there. So I'm going to lean over and press in and towards the transverse and towards the spinous. Come up a little bit. Towards the transverse, towards the spinous.
CA channel back up and running.
So what you want to do to see if you've improved it is you want to see if you can do a good job of skin rolling. So wherever you didn't get a good skin roll, like about right here, then maybe I'll do a little bit more. Okay,
Yes.
so I'm going to go back there and see if I can get a little bit better.
Yeah, absolutely. Skin rolling. It is the manual. It's the manual EMG
That's
technique.
it. That's it. The manual EMG.
When you're rolling that skin tissue, you are assessing, in a way, how much tension is coming from nerve impingements in those areas.
So here it's pretty good, and it could be just a little better right here. So here we go. I would probably do this side from your side, but I thought
Yes, yeah.
I thought I would just do it so you could see it better.
You always have to
Okay.
respect the camera.
Okay. So we could get this a little bit better.
Yeah, you know, you could spend lots of time, and Sharon has showed you how you could do it on the stretch.
So you want to keep seeing, you can keep treating it and see if you can get that skin to really lift up more and more.
Yeah.
So right here, it's lifting up pretty good, but it could lift up a little bit
Yeah,
better.
she could have her legs off the table, be bent over the table, and she could have one shoulder tucked under, one arm tucked under while she's rotating. So that could be good for
Go
stretch.
ahead and press your foot towards me, and then relax. And press it towards me, and relax. Let's go, and press, and press. Good. So here we have about, let's see how many inches. We'll see how good we did. So before we were like 7.5. It was a little hard with the
I think
shoes.
we were 6
Well,
on
here-
this one and 7
Yeah.
on the other.
Here, well, it was the shoes. It was pretty.
The
So
shoes
anyways,
were about
5.
an inch, yeah.
Okay.
Okay, and then on this side, let's see how we did. So here, let's go a little bit stretch, push, and relax, and push, and relax, and push. Good. So we give it a little extra stretch there. And then, so again, with the test, you're just going to go to where it stops, and then we're going to test it here. And this is like 5.5 inches. Okay.
But don't forget that the vastus are involved in that test.
Oh, also,
And we haven't treated the vastus yet.
but
So.
in addition, Justin,
Oh,
one
yeah.
more thing
One thing.
is that if the hamstrings won't contract,
Yeah, they won't shorten.
then it will also, so everything will, it's
Yeah.
really testing a lot of things.
Yeah.
But again,
Yeah.
so we're looking for this to really,
Yeah.
the heel should touch the seat.
Yeah.
Okay?
Yep.
So we still have some more things to treat.
Yeah.
Okay, so let's take a look at you, let's do your strength test one more time. Let's try that.
Yeah, let's try the strength test one more time as well.
Yeah.
You turn over.
On your
Yeah.
back, please. So for the rectus femoris, we need to test the hip and the knee joint at the same time. So we bring it to 90 and 90. Okay. You push into my hand first, and I add 1, 2, 3, 4. Okay, so we improved the rectus
Yes.
femoris strength test. So we got one sign of good.
You did it. You did it.
Yes,
Yeah.
fantastic.
Yeah.
Okay,
Good.
so someone said, what if you had a torn
Well,
meniscus?
yeah, we could try this one.
See
Well, a
what this
torn
one
meniscus
says.
might send impingement, but mostly we like to fix things that are treatable. So what if it was a tear in the meniscus and the whole knee was weak? Well, we treated the muscles and the knee got strong, and then the meniscus healed faster. Then
Well-
and the person moved without pain. Then we could probably say, well, that tear is probably going to heal and be all right. Doesn't necessarily mean you have to immediately go in and fix the meniscus. You could.
Well, we could look at our results
Yeah, look at
and
our
see.
results.
Now, what if the torn meniscus was causing none of the person's complaint?
Right. And
So
what-
maybe the soft tissue treatment will help them a lot, or maybe they'll still need some assistance with that.
Totally. All right, just like this, 90-90, push up into my hand. Then I add 1, 2, 3, 4, 5. Good.
Well, that's
All right.
strong.
Yay!
I passed.
Hey, she
Yay,
passed.
passed.
Okay.
Okay, you passed the strength test, which was good, so that we know that we
Yes.
improved it.
Yes.
So that was great. So super great.
Fantastic.
Okay, so let's. Why don't you go roll over and go ahead and sit up and then stand up. And shall I lower the table down a little bit?
Oh, how
for you?
bad was her Thomas test?
Oh, we could test the
Because
test.
the Thomas was more for the
All
rect,
right,
more for the,
well, it was.
Yeah.
Okay, let's check it. Let's do it.
Back to
Let's
Thomas.
we're gonna do the table.
because the heel to buttocks could be a problem with the vastus still.
That's true.
But,
That's true.
but
The table lower?
Let's make it a little lower.
remember how her leg just kind of stuck straight out on the Thomas test. So let's see if we improve that at all. And Sharon will show you how she might treat it in this position too. You might.
It's a little high step.
Oh, still.
Yeah.
Here we go.
Short.
Okay.
That's
Okay.
right. Okay.
All right. Okay, go sit on it a little bit. Okay, and then you could put your hand underneath, and you're gonna bring it back. Okay, and let's see how we do. Okay, so there you go. So
That
I
is
would
a
say
little better.
A little bit better.
I'd say it's
Mhm.
about 50% more than it was, 30 to 40% more than it was.
Yep.
And you could always
Try the other one.
almost treat in that position to increase the range of motion too. You could,
Yep.
Yeah.
So
so
you hold it there.
yeah.
So,
So
one
she
thing
could
we could do
Yeah.
is we could treat it right. So we're trying to always get you to pass the range of motion test.
exactly.
So we can go ahead and treat it while we're stretching it.
Yeah.
So I'll help you hold it up.
There we go. Yeah.
That's a good spot.
This is one of the main spots that causes the knee pain.
Yeah.
So you can see what makes it better.
So what we're learning from this is that getting the rectus in a really good stretch, and this Sharon is always saying this, really maximize the stretch when you do the trigger points. You will have such a greater effect than just treating in a neutral or slightly stretched position. So the lying in the stomach with the knee flexed is a good stretch, but look at this. This is a very effective stretch for the rectus. And she's getting some real, you can already see the improvements as she's working on it. It is just loosening up and lowering and relaxing. So sometimes it's about getting the right stretch while you're treating. Yeah, you can see, look at it giving in and just loosening up there.
Okay, let's see how we did.
Oh, look at that! See,
That's
a ton
almost
better.
closer to
Almost
pass
close to a
there.
pass.
Mhm,
Very
almost
good,
close to
very
a
good.
pass.
And then
Mhm.
good, yeah.
Okay, here we go. So we're going to take a look at it a little bit while we're stretching it.
If the patient's having trouble, I have often had times allowed them to put their heel on my shoulder or something to give them a little stability. But what a great position, right?
Mm-hmm.
Yeah, there you go. Good. Now, an interesting point here is that this is a simulated gait position. So, not to go too far into it, but the Masters course, you treat in a position of gait. So I was taught to treat people while walking with one leg forward. So put them in a position of walking with their right leg forward, which means their right arm is back and their left leg is back, and the right leg and left arm are forward. Put them in that position, treat the muscles in that position. So the idea here is look at how we're treating her in a gait position. This looks like she's about to jump over what are those things in the Olympic races?
Hurdle?
A hurdle, yeah. She's about to jump over a hurdle. And the rectus femoris is not working in that position.
Okay, let's see how we did. Good. Okay, go ahead and press your ankle towards me. Push. And relax. Okay, so we're going to take a look at a couple more muscles.
Okay, so we're on to the next muscle. So we did the rectus femoris. We're going to look at the vastus medialis and lateralis. Those are the other two quadriceps.
So let's take a look at the medialis.
Sharon, I'm a little confined by the cord.
Oh,
here.
sorry.
So come
Oh,
over
let me
here.
come on over there. Yeah.
Okay, great.
Okay, so the vastus medialis, which is right here, so you can see it attaches right there at the lesser trochanter and comes
Yes.
over here, and of course ends up here at the tibia as well.
Great.
And that causes pretty bad knee pain on the inside anterior part of the knee.
Great.
And it's also the nerve root L4, and it's what you call the buckling knee syndrome one. So sometimes when the knee just buckles underneath you,
This happens to football players. They'll just make a sudden cut to the left or right, and all of a sudden the knee will buckle.
just buckle. Also, it could be holding the patella as well as the.
You won't be able to move it to the side. Yeah.
You won't be able to move it this way too good. And the vastus lateralis, we'll be looking at that next, and then that's also important in the patella moving as well. So here, we do this one next. This one, so we'll treat that when they're laying sideways.
And the good thing is the pain patterns follow their position. The medial one causes medial knee, and the lateral one causes lateral.
That's right, it does. That's right, yeah.
Well, how do you evaluate the range of motion test with these
We're gonna,
guys then?
well, we already did one of the range of motion tests, but we could do a couple of different ones. One of them is the range of motion of the patella.
Oh yeah, the patella, that's right.
So we want to see, relax a little bit, relax, okay. So does the patella come down? Does the patella go inside? Does the patella go outside? Does it move? And does it come down? Which is it's coming down, but not enough, okay? And it's going lateral a little bit, and medial and lateral a little bit. So it's going to the outside and going to the inside, but it's not coming down enough.
Not coming down
Okay,
enough.
Not
Okay.
enough. Let's take a look at the other one. So
The
here,
book she's using is the Travell and Simons book.
yes.
The famous red book, 2-volume
Yes.
encyclopedia to myofascial pain.
So here's the volume 2, myofascial trigger point therapy. So it's myofascial pain and dysfunction, the trigger point manual.
Yep, lower
Right.
extremities, part T.
Mhm.
Great.
You can get those at a good price.
Yeah, they're pretty cheap on Amazon.
Okay, so let's take a look at this knee. So does it's not relaxed a little? Okay, so we want to, it will go lateral, which is going a little bit, go medial, it's doing that some, but it's not coming down enough.
Okay.
So we'd like
Both
it to come
sides.
down more. So we're going to take a look at that.
So that's one range of motion test for the
Another one.
fastest group.
Another range of motion is you can do when they're laying on the table, and you could do heel to the buttocks test, supine.
Now you see the
In this
hip is
position.
flexed, so that takes the rectus femoris out of the
That's
picture.
right. So you can measure from the ischial tuberosity to the heel, and that's like 6 inches.
6 inches, okay.
And
How
then
about
we'll
this
check
side?
the other one. Let's check that side. And so you can go ahead and you go from the ischial tuberosity to the heel.
Yeah.
And then this one here is more like.
Oh, that's really tight on
8
this side. You can
inches,
see
yeah.
that.
Okay.
Okay.
So, all right. So let's see.
You walking
what
around with
we
that?
can do.
Celebrities.
So we're going to take a look at the medialis. So for this, we're going to come about here to the lesser trochanter right here and go just like this to the inside of the knee. Just like that, right there.
Yep.
So I'm going to take a look at that right here.
Is there a famous trigger point, or pretty much this is all along it, right?
Yeah, well, when you get closer to the knee, that's the one that causes the knee pain.
Ah, okay.
This one causes it more, a little higher up.
Would you change anything if there was a knee replacement or anything? Or you'd pretty much treat it the same way?
With knee replacement, you can do a terrific job on getting increased range of motion, full function.
Great.
So I would say, I do think about the fact that they had a knee replacement and consider that as part of the treatment.
Yeah.
And so I will think about that. But people with my first job I ever had in 1985, I meant, was working for 3 orthopedic surgeons, and I treated pre and post surgery. And so I got the good feeling for how the trigger points would fix a lot of times before the surgery, and then I'd also have to fix them again after the surgery.
Yeah. How's that feel, Kirk?
Pretty
Pretty
last
brutal?
one was a bit rough.
Pretty brutal. I heard some groaning.
Yeah.
These ones aren't quite as bad.
Yeah, it's good to breathe.
So we're right on the medial side here, the inside. We're coming towards it. Remember, so the trigger points about right here would cause you to have the medial knee pain. But we want to make sure these muscles get longer because we want the kneecap to relax. Go ahead, relax a little bit. Relax a little bit.
Thought it was.
Okay, there it goes. Well, I could tell because the kneecap went down before and then it stopped going down. So I checked that out a bit earlier. So you did it a couple times. Okay, so here it's going side to side, so that's good. And let's go up and down. It's moving a little more. Yeah. Yeah. Now that's moving more.
Good.
That's good. It's coming along. Okay. So let's take a look at the medial on this side, but let's do this one a little bit while we're stretching, like we did on the other, like we did with the last patient.
That's good. That's good,
Okay.
Kirk. We probably won't have to shoot you after all.
I don't know.
Okay, let's scoot all the way down. Keep coming. You have to sit way on the edge.
We're going to give this a real good stretch, huh?
Good.
Okay.
Whoa.
So I think you just got an awkward position.
Okay, sure. Okay, let's have you come all the way to the edge of the chair. Okay, and then put your feet on there. Okay. Okay, good. Okay. Okay, and then let's see. We'll take you back. Let's have you go ahead and lay back. Okay, what do you think?
That's fine.
Okay, good. Okay, so let's bend your knees a little bit more. Great. Okay, so we're going to take a look at the fasciitis case again. So here's our femur. Okay, so it comes about right here to where the lesser trochanter would be, and then we're going to treat the whole muscle all the way down to the tibia. Okay, so we're going to go ahead and take a look at it here. So here now I can feel some taut bands right there.
Yeah.
Yeah, because we put it on the
He
stretch.
agrees.
So since we put it on the stretch, you can feel the taut bands better. So that's the one of the advantages.
Yeah, yeah. It's not that we enjoy causing pain, but you see, we have to figure out the position where the nerve in that tissue is complaining the most. And we need to make sure it's not complaining in shortened position, in neutral position, and in lengthened position. It has to not complain in any position to be full function. So.
And for him, he'd like to be able to kneel
Yeah, exactly.
and to work.
Yeah, and that's the other measurement is daily
Function.
activities, function, yeah.
Can we have
Well,
function?
there's one.
That's right.
Now here, this is now it's getting closer to where it would bother your knee.
If you're like me and all you want to do is stay in bed 24/7, well then you don't need, full function for me is, basically I need to breathe and be able to reach for food and drink.
In order
Tilt
to
my
go
chin
around.
up, tilt my chin up to watch TV. No, I like a little more function than that. You really realize how much function you need when you become a parent, and then you've got kids that are requiring lots of function.
How old is that little guy?
Oh, he's 19 months,
19 months.
but he is so easy. He's really easy. But yeah,
So here I like to put my elbow into my hip. Then I have my hip pushing.
yeah, you're using your body weight through your hip, through your elbow, through your hands and knuckles, right onto the chin. That's it. It's good.
And it's good to, when you're doing this, is to use everything as straight as possible.
Yes,
And so you're going right through all your bones.
exactly.
Mm-hmm.
The truth of the matter is that not only is it, ergonomically it's better for your joints, but you actually have more control when you have a longer lever arm like that. Your control is better. If you were just pushing with your wrist only, you would have
Then you go like
less.
this.
Yeah, you'd have less
It- it-
control
Yeah,
to be able to.
and you collapse.
Yeah, you'd be have less control over the minute angles and things that you need. Because Sharon might sometimes add a twist when she's in a certain area. She might feel that the fascial plane.
Yeah, maybe I'd like to. Frequently, when I'm treating, I don't go just in. I often am going a little bit this way, and then
Yeah.
a little bit that way,
Yeah, yeah.
and then here, I'm gonna grab it and pull it.
Yeah.
So I'm usually pulling.
So this
While I'm
way
doing the
she's using her
compression.
body weight for the long axis compression, and then she can use her wrist to do some twisting or angle, and wait. So that's really another great trick of the body worker, the master body worker, is that they use long lever arms and body weight to their advantage.
And sometimes it's nice to use this elbow.
Yeah.
And sometimes it's nice to use the other elbow.
Yeah, exactly.
How many of you have a favorite elbow?
Favorite elbow.
Now, one time, I was holding
Your
my-
elbow's my favorite elbow.
So one time I was holding my daughter in one arm, and I was carrying a cat in the other arm, and I slipped on some black ice.
And you had to decide which one to save.
Yes, I did. Oh God, you're right. You're right. I had to do that.
Her daughter is still alive.
That's right.
We don't
So-
talk about the cat anymore.
No, we don't talk about the cat. So I had to save my daughter. So it was my right elbow, and I had to save my daughter. So my elbow, I broke it.
Oh.
So what do you think about a trigger point therapist with a broken elbow?
Oh.
I had to hire somebody to be my right arm.
Oh, wow.
And I did. I hired someone and they were my right arm.
That's not a painless fracture. That's a very painful fracture.
But
Tip of the elbow.
remember they told me I'd never be able to bend my arm.
Yeah, you can see it's still dysfunctional.
Yeah, they said I would
You can't
never
really
be
do
able
anything
to.
with that elbow now.
Yeah. Right, I can't do anything with that elbow.
Apparently not.
No. Okay.
Maybe
So
she get it replaced.
I was going to have you lay sideways.
Okay,
So
which
what would
side?
be the best way for you to go sideways?
We had a question about treating the patella.
Okay.
Sharon would work. She'll show you. She work all around the sides.
So usually I like to put the body support. So why don't you sit up for a second? I'll put the body support underneath you. So I'd like to have you lay sideways. So I'm going to put the body support system underneath you.
So to get more of the vastus lateralis.
Yes?
Yeah, this is
Okay,
a
so
great
Escalada.
position. All of you
Okay,
should
great.
be doing this. You should have tried this by now because this is a phenomenal position. Patients love it. It's so comfortable. You get a little cervical roll there, and they don't even want to get off the table. It's so nice.
Okay, so in this position, now you can actually see how much improvement you're getting while you're doing it. So here, yeah, I can often I'll put a little bit of I'm putting just a little bit of a pressure on it,
Yep.
and then at the same time, I could treat it. So I'm gonna put a little pillow under his knee.
Yeah, between the knee, it's good to have a pillow there.
Oh, that's where I found that.
You got
Maybe
this one on the
give me a
side.
big pillow on that side. There's a bigger one. Good, that's a good start though.
You want to use this guy?
No, this is good enough. Okay, so here's our vastus lateralis, and here's our greater trochanter, and then it's going to come down, attach here. So let's go ahead, let's take a look at a picture of it, because it has nice pain patterns. So take a look at here. So here's our,
Huge all along.
so it causes pain all the way up to the hip and all the way down, kind of like a curve underneath the kneecap.
Like a putter.
Like right underneath there. And then you can see here it's attaching here a little bit onto the tibia, and there's a little bit of a little ligament, the lateral collateral ligament we'll look at there. And then you can see it causes pain in different all over on the outside of the knee. Okay, so give it a nice treatment. Okay, so find the greater trochanter. Then we're going to come into it. So what do you, oh, that hurts there, right?
Yeah.
Oh, okay. Not that bad, though.
Means you're doing some less working.
Yep.
Okay, so here, so we're going to give it a little bit of a stretch while we're pressing on it. So our vastus lateralis. How are we doing on time, Justin?
Good. We've got 5 minutes to 9, and I think people are probably getting a little, after a long work day. We should probably be pretty quick to the rest, I would think.
Okay, we could do that.
Yeah.
Okay, good.
You got one.
Good. Okay, so a lot of times you got a really good one is when you press on it, and all of a sudden the knee bends more. And part of the vastus is kind of in the back here, so maybe that kind of acts a little bit like a hamstring. So I'm going to go ahead and treat that a little bit, stretch this way.
Yeah, the very back part of the vastus lateralis, it's good to actually, it's different than the rest of the muscle. It does act a bit like a hamstring, so it's important to know.
And even when you're doing we could do the standing toe touch also for that test. That also could give you the vastus lateralis.
Oh, wow.
Do you want to hold this? Sure. Okay.
Okay, let's see how we're going to do. All right, let's give it a little stretch. Go ahead and push your foot towards me and relax. And push it towards me and relax. And push. Come see how close it's going. So now it's one finger. Okay, 1.5 fingers. See? There you go. Push towards me and relax. So it's getting real close. That's really close. So you did really good. Super great. Now we just have to see if you can kneel. Okay, let's turn you over on the other side. Get your shoulder in that little crevice under your neck there. Let's go ahead and put this under your knee. Okay, so again, we're going to go ahead and treat it. So here in this position, so you see we got about 5-6 inches here. Let's see, I got my measuring tape right here. So we're starting out, and we're gonna, so I get a little bit of pressure here. I'm gonna go ahead from the seat to the heel, 6 inches. Okay, so we're gonna go ahead and treat that while we're So here we're going to find the greater trochanter. Can come just a little bit below it. We're going to go ahead and press right there. What do you
Okay.
think of that?
Yeah.
You can feel that?
He feels it.
How painful is that?
You know, pretty good.
Okay, good.
I can really do something.
He's
Something?
talking, he's not gasping, so it mustn't be
it's not too
bad.
I'm used to this.
Okay, oh, so I get touched there, and all of a sudden, now it's closer. It's a little bit like 5 fingers.
That was a pretty.
So we're coming down towards the knee. And
More there.
so I'm just giving a really light pressure, like almost like just, but I'm noticing if I press a spot, does it come closer?
They're asking lateralis?
Yes. Oh, yes.
Yes.
I'm vasting lateralis. And let's do a little bit while we're stretching it this way. So here's our greater. So come just inferior, and we're going to put a little bit on the stretch here, and a little bit on the little right here. And as it seems like you could take up the slag, as it seems to get a little stretched a little bit more. Okay, good. Okay, that's that. So here I'm just looking at this little collateral of the lateral ligament here. So I was just going to take a look at that. And you noticed it?
Yeah.
So it comes over here to the fibula. So right there. The fibular collateral ligament. There, right there. Okay, let's see how we did. So we didn't treat it too long, but let's just go ahead and see. Go ahead and press your foot towards me. Push and relax. And push and relax. And push and relax. And push. Good. So we have 3 fingers. Good. Okay. So we improved a little bit. So I like to see at least 1/3 improvement, or 50%, or 100%. And so we improved. That was good. So let's go ahead and have you lay on your back for a minute. And I guess I want to take the body support out underneath. Okay. Go ahead and lay on your back. Okay, so with your little bit with your legs. So scoot up.
That's right. That's right.
Yep. Yep. Good. Thank you. Okay, let's see how we did with our knee. So let's see how we're doing. So let's see if our kneecap comes down, up, down. That's nice. That's a little better.
Oh, yes.
That's what you call better.
Feels more.
Yeah. So it kind of moves. Yeah. Let's go inside and out. It's moving. So that would kind of help us to be able to, if it can rotate under, then it's going to feel better when you're kneeling on it. Yeah?
Yeah.
Yeah. Let's see this one. So here we come down. This one's a little tighter. This one needs a little bit more tension. Okay, so you could treat your right down the center, down the lateral and the medial. And that will help you with this one. Relax a little bit on this one. Let's go down, side, side. So it seems like this one we want to get a little bit better.
Okay.
Okay, so let's do a little bit of strength test.
Okay.
Also, we could do. So let's go ahead. Let's go ahead and hold it up there, and let's go ahead. And I'm gonna push. Have you push up towards me? Push, push. And then I'm gonna add some force. Strong. That's what you call strong. Okay. Okay, great.
Functional.
Should we test the strength?
Oh yeah, you can do it if you like. I did one. You
Oh,
did
you
the other.
ready?
Well, you do it. You do this one.
Okay,
That's good.
so for the
I did this one.
quadriceps, for the rectus, I'm not for the rectus. We did both joints. For the vastus, we I'm sorry, other side, this side.
Yep.
Like that. Okay. So you have one hand on top of the knee. This hand supports this joint, and so for both of them together, you push straight up into my hand, Kurt. Push straight up, and I add 1, 2, 3. That's plenty good, strong. And to get more of the lateral, vastus lateralis, you turn inward. Remember creating that straight line, and then you push down and in, push up and out to my hand, and 1, 2, 3, good. And then to push down and out like that, bring the knee up. And I'm gonna push down. You ready? Push up in my hand. Okay, and I 1, 2, 3. Okay, good. So they had good strength. Okay. Oh, during testing, you want to tell the patient not to grit their teeth or hold their breath. They will do that. So just breathe normally while I'm doing your strength test, and don't clench your teeth. Okay. Good, good, good. All right.
I think you wanted to do this one. This leg.
Oh, no, it's good enough. I
That's
should.
good enough?
Yeah,
Okay.
that's good. All right.
We did it. We did
Yeah,
it.
yeah, yeah.
Okay. So
All right.
let's roll. If you could go roll to one side and then go
Yeah.
ahead and sit up.
We still got a number of muscles to get through, so let's get through.
Sure.
Okay. Okay. Then go ahead and stand up. Okay. So go ahead and sit down and relax for a minute. Okay. So another area we're going to do is the hamstrings and we're going to do the gastrocnemius and the soleus and the back of the knee muscles, the lock and unlock one. So we're going to do the lock and unlock, and we're also going to do the squat test. So if you could go ahead, come over here, and if you could go ahead and go towards touching your toes.
This is a good test for the hamstrings.
So let's go ahead. We're going to test, and so here we're going to test from the middle finger to
You
the
want my
floor.
knees locked, right?
Yeah, for this one, yeah. Over there. Oh, okay. Okay, so that's 6.5 inches. So that's good. Okay, let's have you come up slowly. Wait. Okay, so let's feel you lock and unlock your knees. So let's see if you can lock them. Let me feel it. Okay, lock. Good. And then let me see this one. Yep, she can lock them. That's good. You can do it. Okay, so step forward, and we're going to have you do.
That's for which muscle? The popliteus?
Yes, the popliteus.
Okay.
Yes, yes.
Lock and unlock is for
Yeah.
the popliteus. Good.
Mhm. Okay, so next we're going to have you come down, and you're going to do a deep knee bend just as far as you can go. And so we're going to measure from your ischial
need to hold
tuberosity
on to something.
to the floor. Okay, there you go.
If you hold something,
No.
it could go wrong. Okay.
No, I don't want you to.
Oh, you don't want me to hold
No.
anything?
Mm-mm. Okay, so you're going to go just like that. Okay, and so that's like 19 inches. So
And what muscle do you think that is? Soleus.
that's right.
Yes.
They know.
Last time I was 17 inches, so I'm tighter. But that was
No,
me.
16 is better.
No. Oh, it's better if it's
Yeah.
yes. But last time we did that, I was 17
Mhm.
inches.
That's worse.
Yes.
Okay.
But that was a long time ago.
Oh, a long time ago. Okay, good. good.
Pre-accident.
Oh, okay,
Yes.
okay, 1 inch difference. Okay.
Yes.
All right, so let's take a
All
look at treating the hamstrings,
Mhm.
and let's take a look at the popliteus and also the soleus and gastrocnemius.
Okay.
And we're gonna do another test when you're laying down.
Okay.
Okay. All right, so let's have you go ahead and lay down on your tummy.
So we're kind of working the back muscles, the back of the leg muscles and thigh. So we
Put
did
them
the
together.
standing toe touch for the hamstrings,
So we did. So we're gonna do for the soleus, the bent knee.
the knee bending, because the soleus, remember, just like the rectus crosses the hip joint, but the
Soleus.
vastus does not.
Mhm.
The gastrocs cross the knee joint, but the soleus does not.
That's correct.
So
So here we're looking, do we have at least 15 degrees of dorsiflexion? So here is straight, so go ahead. And that's pretty good, but let's see if we can get it a little bit better. So we could give it a little test also. So we could look at how many degrees. So we could go put this right here, put this along where the foot is. So let's go ahead and give it, all right, and let's go ahead and measure that. So that's about 10 degrees. So so let's see if we can get it to 15 or 20,
Okay,
something
great.
like that. Okay, and then the other would be the gastrocnemius test. So this would be, and here we're doing a little better with that. You can see we're getting about 20, more than 15 degrees there. So the soleus is a little worse than gastrocnemius.
Yes.
And let's show you yeah, this is good. So this is the straight leg dorsiflexion.
That stretches two joints, so
Mhm.
that's how you get the gastroc.
Okay, let's look at the popliteus.
And the popliteus muscle.
Yeah, so here is, so this would be the stretch, and that would be the contraction. So it's let me get my finger right on it. So that's the stretch, the contraction. So it doesn't want to do the contraction. I can feel, she notices that. So I feel it stretches, but it doesn't want to contract. Yeah.
All right.
So let's check that popliteus right here. And let's show you a picture of it. Okay, this one doesn't want to contract at all, and so it just gives us a slight stretch, but no contraction.
Okay.
Okay,
And
so
heel the buttocks for the, shortening for the hamstrings, but we already did that
well,
for
we
the
can
quads. Yeah.
look at here. Yeah,
Yeah,
so here's
that's
our heel to buttocks.
Do you want to see how I
6
would
fingers.
do the strength
Oh
test
yeah,
for
let's do
these?
the strength for test for those.
Okay.
Yeah, let's do that.
So you could just stay in that position.
Okay, great.
Okay, so for the hamstrings, bring the knee not up to 90. There's the muscle fibers overlap too much at that point, and they're locked, and you wouldn't really have a good strong test. So you bring it up just to 30, okay? Hold that right there. And what I do is I would use a straight arm because this is not a very strong area for the tricep in this position. So say push up into my hand, and then I add push up into my hand. You're pushing down. You see how you're pushing down? I haven't pushed down yet. Just push straight up. Now I'm going to add 1, 2, and there's nothing there. So hamstrings are definitely showing a lot of problem. Okay, so push up into my hand, push up, and 1, 2, there's nothing there. So neither of those. So both those showing problems, okay? Those are the hamstrings. You could differentiate between medial and lateral by turning out, and that would give us more of the medial hamstring, or turning in. Ooh, it doesn't turn in. And that would give you more of the lateral hamstring, okay? What was the other one? Oh, popliteus. Okay, so knee 90 degrees. You have them turn in like this. Keep that in, and I'm going to twist out. So you can see how much foot is bending. The foot doesn't even stay straight, so you know the popliteus isn't doing anything. She's using her all sorts of foot muscles to try and substitute. So twist in. It can't even hold in. So, and I just twist out. So twist in, and I twist out. Oh, just gone, right? Push, 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 push. Okay. No popliteus muscle at all. That muscle's same thing Sharon found. So same thing here. So turn in. Ooh, it doesn't really want to turn in. And I'm going to twist out. You don't let me twist out. See, it just comes apart. Twist, twist, twist. No. Okay. All right.
Got it.
The gastroc, different than the hamstring, what you have to do is you have to point the toes. That's how you point the toes and relax a little bit. Relax, honey, for just a second. Yeah, down to 30. Now point the toes all the way. Now push up into my hand. Now I add 1, 2, 3. Okay, amazing, right? If you have the foot flat like this with his hamstring, push, push, nothing, okay? But when she tenses this, that foot flexion, that puts the gastroc in the mix. Push 1, 2, 3. Okay, so
So she's
gastroc's
strong
good.
with gastroc,
Gastroc's
weak with
good.
hamstring.
Hamstring's a mess.
Weak
and
with
popliteus.
popliteus.
Just one more time on this side. Point the toe to engage the gastroc. Push up into my hand. And I add 1, 2, 3. Okay, good. So,
Super.
popliteus,
Really need help with that.
really need help. Hamstrings really need help. The gastrocs are pretty good. Soleus is a little bit trickier to test. You point the toes, and then I actually push down and out. But that's plenty strong, and I don't think it's a great test, in my opinion. Push up, and then push up. Yeah. I don't do that test very often, but that's how you test it. It'd be hard to find a weak one, pretty much. But all right, good.
Okay. So, how's your comfort level? Should we put the body support system underneath you?
Yes.
Okay, so why don't you come up on your hands and knees, and we'll do that.
So we're gonna hit those 3. We're gonna hit 4 muscles. I'm sorry, the strength tests are not on the poster. that is applied kinesiology, and you could look it up. You might be able to find some things online.
Well, you wouldn't want to have any more on that poster.
No, not anymore in that poster. The poster is just for range of motion tests. The strength tests are not on any poster that I know of. There's a book by Walther, Walther, that tells you every single thing you could possibly need to know about applied kinesiology. Really amazing book. You could spend your whole life studying it. But they have the strength tests and everything that you could need to know. I mean, acupuncture, holographic, amazing stuff, isn't there? But we're showing you all the strength tests in this course because you might like to do them.
Oh, it's so important because
Yeah.
you have to have the length and you need to have the strength.
Yeah.
So as soon as you have the length, then you want to go for the strength.
Basic premise of every strength test is line up the muscle so it's as straight as can be. The fibers are in a straight line. Then push 90 degrees against that straight line. Have them push into you first to engage the muscle, and then you add 3 to 5 increments of strength.
So one of the
against
things
them.
that causes significant knee pain is the lateral, the biceps femoris, the lateral hamstring.
Yeah.
This one causes some medial, but more buttocks.
Yeah.
So
So,
the
this one goes
semitendinosus
up, medial side goes up, and lateral side goes,
Goes down. So the more important one for pain in the knee would be the one
Yes.
on the outside.
Exactly. And I find that they get a lot of problems at the Golgi tendon organ where they insert right below the knee onto the tibia. Lots and lots of little nerve bundles in there sending signals to shut this off. Remember, where would the Golgi tendon organ be on the other end would be right at the sit bone, right? The ischial tuberosity right there. And then they'd be right there beneath the knee on the tibia is where the other Golgi tendon
So
organs
this
would
is
be.
where you want to start. So here's our ischial tuberosity.
Yep.
So let's feel it, and we come just right below it, and you're going to go right onto where the muscle attaches.
Yep.
And let's go a little bit lateral to get the lateral attachment right there. Right on it. I feel we're right on it there.
Yeah, yeah.
And we're going to come down inferior. And then I like to give it a little stretch. So I come over like this and stretch the lateral a little bit
Wow.
while we're treating it.
How's that feel?
That's, I
Wowsy?
noticed it quite a bit.
You're noticing it quite a bit. Great terminology.
Oh, yes.
So if I have the table down lower, I might use my extended arm
Yeah,
rather than my elbow.
yeah.
So coming in, looking at the lateral.
And we mentioned that correlation finding that George Goodhart had with vitamin E and problems with a lot of the muscles in the thigh and back of the leg. It's kind of interesting. Hard to prove clinically, but they did show really interesting matchups between those clinical findings and the blood work. So, you know, if you got someone who just can't get better, maybe they don't have enough vitamin E, and who could
Well,
use a little
another thing you
vitamin
could
E?
do is you could test their blood
Yeah.
and see what they're low in,
Yeah, yeah, it's always good.
and then we can see whether or not somebody might need some attention there.
Yeah. Blood work is not the best at nutritional values because, you know, what's in the blood may not be what's in the tissue. But some tissues concentrate nutrients up to 8 times the amount in the blood, you know. So it's hard to tell exactly, but basically a healthy diet helps everyone. And a good multivitamin, not like a Centrum, but something from a high quality vitamin source it's just a good idea for probably most people.
Okay, here we're going to go to its attachment on the tibia and close to where the fibula is here.
Yeah, see, it comes right down below the knee there. Yeah, the Walther book was, I think it's just called Applied Kinesiology, and it's by David Walther. You could probably get that at a good price on Amazon also. Some student has it. If I wrote all sorts of good notes for you in it.
Push towards me a little and relax and push and relax and push and push and push. Good. Super. So I'm going to take a look at the medial hamstring.
Those are the semimembranosus and
And yes,
semitendinosus.
the semi and the membranosus and tendinosus. Now the tendinosis will attach on the pes anserinus.
Yeah, that's right down there where the three muscles converge to make that little pes anserinus. Is this more or less tender than the lateral?
Oh, the lateral was extremely
Lateral.
tender.
Lateral's
This one
more
feels
tender.
good. You could go deeper in there.
Okay.
Gotcha,
This
gotcha.
one feels good.
Yeah, that was
Okay.
the tightest one where I
Okay.
feel the most pain. So.
Okay.
And again, it's important. The pain is important because that's the threshold of function. If you understand that, then you understand trigger point therapy. Pain becomes the limiting threshold to function. So when you start to function and you reach pain, then your body will naturally stop any function beyond that point.
Go ahead and press towards me and relax.
So if
And
we can
press towards
reduce
me.
pain, we are increasing the threshold of function. So that upper limit, the more painful chemicals we release, the more painful bands and taut bands we release, the upper limit, the higher the upper limit of function becomes.
So here, I'm taking a look at the popliteus. So I'm contracting it and stretching it. Contracting it and stretching.
Yeah, it just unlocks and locks the knee. It's just like a little can opener at the end of the joint. Just does at the end of an extension, it just causes a little twist, blink, to lock the knee. If it didn't, you could get very tired knees. People who have bad popliteus, they get no break, because when you lock your knee, you should have a break. You should be able to rest on your knee joint. But you're standing up for a long time and your knees get really tired, your legs and thighs, hamstrings get really tired. It could be your popliteus is not locking the knee for you.
Okay, so we're coming a little closer to the seat here.
Yeah.
That's nice. We're coming right along. So we're looking now. I'm going to look around for a little, whatever it might be stopping it from coming close to your seat.
And of course, the standing toe touch is one way to measure this, but
Right.
there's lots of other things that go into that standing toe touch as well. So things with the low back.
Yes.
and whatnot,
Oh,
so.
many things. Yeah. Gastrocnemius.
Yeah,
for one.
gastrocnemius is one. Yeah. So here we go onto the
So we're coming
gastrocnemius.
along to the gastroc.
Treating it on a stretch, of
Stephanie,
course.
could you pull out the gastrocnemius? And if you could show us the popliteus, that might be nice too. Okay, popliteus. You say tomato.
Popliteus, that's what I
You
say.
say tomato, I say tomato.
Nobody says tomato. Pretentious people say tomato.
Tomorrow.
And popliteus. Oh. I see. Maybe if I had some cool sunglasses like Kirk, then I'd say popliteus.
So here's the popliteus.
Popliteus, I should have known.
I said
Another one.
popliteal.
All right. I guess I'm losing this one. The way to, can I show you the way to look at the popliteus is you put your hands like this. That's how it looks. Okay, so it's attached down here to the tibia, and it wraps up a little higher on the femur like this. So your hands would be like that. So meaning that this would be since it's going like that would be the right femur, right leg. You see? Okay, it starts on this tibia and goes up onto the fibula and into the tibia right there. And it just helps twist the knee into a locked position and unlocking it. Okay. And the gastrocs, the impressive biker muscle, this big, lumpy, awesome-looking calves. Those are the, two bellies of the gastroc, lateral and medial. And they do cross onto the femur, so they are a double joint muscle. Okay, and the underneath, flat like a mattress underneath them is the soleus, and that does not cross. That's just like a big flat muscle attaches all along the tibia all the way down to the calcaneus. Causes all kind of heel problems. And here you can see that the trigger points are right behind that knee, a lot of those, and they cause that referred pain. Pretty much where you'd expect them. Referred pain is about where it would be. But except for this spot right here. You would not expect really bad plantar fasciitis pain to come from a trigger point up here, but it does.
So I just was going to review here. So for the back of the knee pain, the gastrocnemius would be the most likely, then the biceps femoris. So the gastrocnemius, then the biceps femoris,
The lateral
the
one.
popliteus, the semitendinosus,
Okay.
and
medial one.
membranosus, and then the soleus, and then the plantaris is the least likely. So, so coming here and all the way up
Tiny little plantaris muscle.
and coming up over here, just like that. So
I just thought we needed one more in there.
yeah, yes. Yes, we got to stand on our toes
Yeah.
like a ballerina.
little extra kick there to help the gastrocs and soleus.
So we could go ahead and come on our ballerina toe
Yeah.
and see if we can feel it. And come on our ballerina toe. There. Okay, so give that a nice massage.
This area is going to require a lot of work. You can see how much of a jump and a twitch those nerves think they have the right to scream, yelp whenever they want. And so, you know, you're going to have to work on them until
Twist
they
towards me.
tone down.
Push. And relax.
When-
And push. Good. And now bring your heel towards your seat. And push towards me. And towards you. And towards me.
Right, hon? You got to get all those muscles, those little tiny trigger points, those tender spots. They're screaming bloody murder. Got to get them to say,
Push towards
okay, I will
Bring
function.
it towards you.
We go through the pain to the function that we need. Because pain indicates when there's damage that we need not to move a joint or a muscle because of damage, but they tend to stay that way long after and complain far too much. Trigger points are like erroneous, message of damage that don't need to be there. So we've got to get rid of those to allow function. Did you treat the popliteus also?
I did.
Yes? Okay,
Mhm.
cool. Oh yeah, that's right. Yeah, you're doing that. Yeah. I forgot. All right.
Okay. So so here we took a look and we treated all the muscles here on this side. Let's
Great.
take a look on this side.
We should probably move faster. We only
Oh.
got a couple minutes left.
All
We
right.
may, we may have
Sorry,
to let
sorry.
you do that one on
Okay,
your
we'll
own.
have to let you remember we did that already.
Yeah, yeah.
Okay.
So
So
we want to retest the muscle strength real quick. Here,
Let's do it.
let's just do that real quick. Let's see if we were able to improve this popliteus. So we should visibly see a difference because she couldn't even move it into position. So turn in. Okay, that's better. And I'm going to twist out, hold. 1, 2, 3, good. And you see I let go and it snaps. That means that muscle is good. Let's try with the foot like this. It's hamstring time. Elbow straight, push up into my hand. And then I add 1, 2, 3, good. It was giving a little bit, I would say, but it's a lot stronger than it was. And how about, well, this was already strong. The gastroc was already strong like this. So, good. So some improvement, definitely.
Okay. So we can have you go ahead and if you come on, if you slip off the table.
Now, we just did the adductors last time and gracilis and stuff, so we could, what do we have left? Those are the ones we have left.
Adductors, yeah.
Adductors.
Yeah. Well,
and
we could do
gracilis.
the gracilis, yeah. We
Yeah.
can do gracilis. So
All right.
let's take a look at adductors and gracilis.
These are the last two muscles, folks, and then you will have completed everything that could cause knee pain.
Okay. So let's have you go ahead and lay on your side.
Oh, on my side.
Mhm.
We're doing this side. So you want me to lay on this side?
Well, which way would you like us to do?
The same one.
Same one. Let's get one
The
good.
problem.
Okay, so
Let's get one leg good.
Yes, let's get one leg working.
Well, the worst leg.
One
We're
that doesn't
working on
work
the one
well.
that's worse.
Yeah, work on the worst leg.
Okay, so this is the one that I was going to treat. So then you probably want. I know.
Okay.
Then you have to do the other
Oh,
one.
the other
I'll face it. So in this sideline position, the leg that she's treating for the medial side of the thigh here,
Just turn your
the
leg a
adductors
little
and
bit.
gracilis, will be the downside leg. I think that should make sense to everyone.
Yep. Okay, so we're going to take a look at the brevis, the adductor brevis. Well, we didn't do the range of motion test.
Oh, yeah, that's true. Should we have you line your back real quick for the range of motion test?
Yeah, we didn't do that.
Can I do it on the?
Yeah, you can do it on
Uh-huh.
those cushions,
Yeah.
yeah.
We'll do it on the cushions. Okay, so the range of motion test for this one.
Yes.
So we're going to go ahead.
Which one is like?
Okay, this one. Okay, so we go ahead. So we're going to we're going to measure from the lateral knee to the table.
Or you could put the heel on the
Or
inside
yes,
of
we
the
could.
thigh, too.
Another way to do it is come like this,
Yeah.
and then you could measure from here to here.
So not too bad range of motion-wise.
Yeah.
Okay. Not really bad at all. Okay.
So it's about 3,
Yeah.
1, 2, 3.5 inches here.
Not too bad.
Mm-hmm. And the way I like to do it, from lateral. And so this would be about 6 inches.
Okay.
Okay.
Right. And,
Well, I actually would rather treat your adductors this way.
And
So
then-
stay there then.
and then also
The straight leg one.
the straight leg,
Yeah.
bring
So
it
here we're going to take it up
and let it
and
come
to the
out.
side.
And it should get to 90, so not
It's
too
not-
bad,
not
but it's
quite
not
to
quite to
90.
90.
No.
And you want to see the strength test real quick?
Oh yeah.
That was real easy. All you have to do is you brace this leg down, and then this leg push in toward the other leg, ankle toward the other leg. And then I add 1, 2, 3, 4, 5. Okay. So that strength test was okay. So the range of motion, fairly good. Strength, fairly good.
Okay. So here we're going to see the femur. Stephanie, could you pull out the picture that we're using, each thing we're doing? So it's over there. Okay, so here's our, so here, find our femur. We're going to look at the longest and the brevis. So let's go ahead. We're going to find the femur. We're going to come a little bit in and press right in there.
And not nearly as painful as some of the other spots?
No.
Okay, so
I can tell
adductors.
immediately.
Adductors are in better shape than some of the other muscles we've looked at.
Because they've been worked on by you.
And I was going to say, we worked on them in the last class.
We
So,
did. We did work on that.
I've
Yeah.
done that before. Not
So,
too long ago.
yeah, that's a...
Longest and brevis. Adductor, longest and brevis.
referred pain is nothing too special with the adductors except that the magnus causes upward referral into the pelvis. Otherwise, they're pretty local. Is that them?
Yeah, put it over here. Put it right here.
Yes. Adductor longus and brevis.
So here it is. So it's actually onto the femur and then on to the pubis.
Yep.
Onto the pubic ramus there. So here we're going to come. So we just did right here by the femur first. Then we're going to come close to the pelvis there.
And actually, the referred pain is actually, you can see why it comes right down. It's a little different than I was saying. It's actually
Oh.
quite different. You can see the adductor longus and brevis comes right near a ball right around the knee, kind of
Well,
like
you were
the rectus
talking about
femoris.
the magnus.
I was talking about the magnus, yeah.
Okay.
And then up here, all the way up by the hip there. So, yeah. Now let's take a look at Magnus. Is Magnus right around here?
It's not too far.
It's got to be. There it is. Here's the Magnus. Now you can see the Magnus. That's where the muscle is.
And then see how it goes
And-
up into the pelvis.
Yeah. And the referred pain is pretty much right where the muscle is, but then there's this referral up into the pelvic cavity, right in where the organs are. So a lot of mistaken organ problems due to those trigger points.
I'm just going to treat it a little bit while I'm moving it so I can see what it's doing. So here,
So that's shortening, and that's extending. Shortening, and lengthening, and shortening.
so I can feel the parts that aren't working. So I can feel right there, it's not working. So I'm just going to hold it there and just move it just a little bit.
And again, by not working, you mean
Oh,
that
it's going into like Charlie horse or a
It's-
muscle contraction,
yeah,
involuntarily.
yeah.
I mean,
It's-
just
it's
because
not
you put it-
smoothly moving through its
Yeah,
range of
yeah.
motion.
So if you put it into the shortening, passively shortened position, and it
Yeah.
goes into contraction,
Right.
you know that that's one of its dysfunctions.
Yeah.
So then what's showing is that when you're trying, it's not really under your control.
Yes. It's an indication it's got a nerve circuit in there that's causing that, you want to be in full control of those muscles.
Okay, next we're going to take a look at your gracilis.
Yep.
So if I can have you turn sideways and face towards Kirk.
Do we have a range of motion for gracilis? Not
No,
really, right? It's
not
kind of like the
really.
adductor.
Yeah.
Here's a strength test. You want to line your back? I'll show you the
Oh,
strength test real
good.
quick.
Okay.
All right, strength test for the gracilis is a fun one, actually. Okay, since it's in here, it brings the leg kind of down and in, so you twist the ankle so that it's turned in, and I brace this here, and I'm pushing up and out at a 20 to 30 degree angle. So you push into my hand, and I push up and out. 1, 2, 3. Pretend it's weak. It would look like this. Push, and then it would go up like that. Okay, it would go push in, and then it would 1, 2, break. But strong, like she has it, turn in and push in, and then go 1, 2, 3. Okay, so it's in at a 20 to 30 degree angle down into the table. That's gracilis.
And this test that we already did for the adductor is good for the gracilis.
Yeah, the adductor and adductors and gracilis tests are similar.
Okay.
Last muscle, folks.
So here is a tip. So it's the one that sort of sticks out right here, right there, and then so that's where it attaches on the pelvis, and then down to the pes anserinus.
Yeah.
So we're going to go ahead medial tibia.
Oh, you're very welcome. Yeah, it's a great review. There's never actually a class that Sharon has taught that I have thought all the way through, oh, I already knew this. I always find, oh, that's a great review, or, ooh, that's really cool, yeah. She adds a little spice to every class to do things that, you can only get that kind of knowledge from 30 years experience, so. And we've had some people enjoying the addition of the muscle testing in there. That's cool.
That's good.
There's rarely a class that has that too.
That's
I'm
fine,
not
isn't it?
bragging, but I don't think anybody quite teaches it as well as I do. Actually, I've taught it in several different states, and I even did a research project on it at Vanderbilt, exactly how to do it and what was scientifically valid about it and what wasn't. And the important thing is to get that conscious engagement. Always and always, the patient has to push first. Otherwise, your results are pretty much useless.
Okay, so we're right on that gracilis here. So we're going to get right up at the attachment. And we're right on that gracilis right there.
And remember the trigger points spread. So when you get a primary trigger point, its referred pain area will activate trigger points in those referred pain areas.
So a key trigger point will refer to other areas and activate other trigger points. Sometimes that's called satellite trigger points.
Exactly. Thank you. And how about a hand for all of our devoted, what do you call these?
Viewers?
No, you guys, you come in and you're, I'm going to call them dummies. They're not dummies.
Oh,
are they?
no.
Oh, I
They're-
think
they're
what the
what-
people watching.
No, all the people, you guys
are,
come in every week and help us with, what are they called?
Our models.
People?
Models, that's what they're called. The models coming every week. Thank you, everybody, for all the help.
And other people who aren't too far away, or even if you're far away, you could come and be in the class too.
Yeah, definitely.
And we could test you and evaluate you. You can do the range of motion tests and dance with us.
Yeah, if you've got the time and you want to come up to Chicago on a Tuesday night, absolutely.
Yeah, we'd like to have you.
We have an awesome reality TV show coming up very soon.
Oh, yeah?
We're starting a show called Woman versus Pain. Yeah, we have a truck, a van, a really nice Euro van, like there's a Mercedes Sprinter, set up with a treatment facility inside the van. And we're going to go around the city of Chicago and other places where we're invited to show people, victims, yeah, show people that, model victims, to show people how to overcome their own pain. And we're going to be televising it and making it kind of really entertaining, so it can be, who's stronger, Pain or Sharon? And we'll see if she's going to take the challenge. People who think that their pain can't be beaten, well, Sharon's going to take them to task. So that show, it's necessary because entertainment is how awareness spreads, and we need more awareness of this work.
That's right. We got to make it a lot of fun.
Yeah. Oh, we're going to do it through Periscope so everyone can watch
Okay,
it,
so let's take.
and we'll see if it gets picked up from
We're
there.
going to measure a couple of things. So go ahead and lay on your back again. Good.
Thanks.
So we're just going to take a look at your range of motion test. Okay.
Well, we got the signs being printed, so maybe by the end of this year, or maybe in the very start of next. Maybe next month if it goes really fast. Who knows?
Okay, go ahead and press your knee up towards the ceiling. And
Yeah,
relax.
yeah, we'll
And
email you
press
for
it up.
sure.
And relax and press it up. And relax and press it up. And relax and up
Good.
and up and up. Good.
See, it can
So,
be done.
so here's our test here.
Yeah.
As you can see, we're
Totally down.
doing pretty
now.
good there.
There's no measurement there. It's on the table.
Yeah, yeah. Well, we're going to measure from the lateral kneecap.
Lateral kneecap.
Okay, so there we go. And then here we went from, also did it like this, and we'll go from the lateral kneecap to about there. So that's 3.5 inches,
So,
and we were about 6 inches or so
6,
before.
yeah.
So that was good.
so we got some improvement there too.
Then here we went up this way.
Should,
That's nice. That's a little better.
That's a little better.
should go right up to 90, yeah.
Okay, see how we do
And then
this
should
way.
come down to 90.
Not quite at 90 here. so,
But that's all right.
so let's take a look at the gracilis here. So I'd like to see if I can get people to pass the range of motion test.
Yeah, Sharon makes that a goal. She treats them in the position of testing until the function is reaches its.
Well, this one isn't probably going to do it.
Yeah, it's not going to reach
It
its.
did, it did lower though.
It did.
lower. It
Okay,
did lower.
it did lower. Okay, push up just a hair.
I can't.
Oh, no, that's too much. Yeah, we won't do that. Okay, so next, at the end, then I'd like to do this at the end. I'd like to see if I can get the whole kneecap to be like a well-oiled machine. So I'd like to go ahead and feel it in all different positions and see if I can get it to be as flexible as possible. So I go ahead and move it around while I'm treating it. So I think we forgot to treat one muscle, Justin.
What did we forget?
Sartorius.
Well, you can watch the last class. Sartorius is
Oh,
very
so
similar.
push
We
first
did that
knee.
a couple weeks ago.
We did do it a couple weeks
Remember,
ago.
it's going to come from the
And push
anterior
it in.
superior iliac
Push
spine, and it's
Wait,
going to
wait,
wrap
he's
around
working
to
on
the
that. I
knee
can't
there.
concentrate
All
on
right.
both.
Push your ankle in and relax and push it in. Good. I just was thinking about that. Sorry.
Very similar to
We
gracilis.
got it. Yeah. Yeah. So it's going to attach on the same spot.
Yeah.
Okay. So you're bending really good.
Okay.
So the knee's doing really well. So we could do a couple of our strength tests and see how good we're doing.
Oh, we did those already. Actually, she passed both
Yeah,
those.
I passed.
Oh, we did them all.
Yeah, she already did.
All right.
I'm passing now.
Good. All right. So usually I finish it up with moving around just like I was showing.
All right.
Okay. So it looks like we did the amazing knee pain relief program,
We did the whole thing.
Yes.
including the Sartorius.
Yeah.
So for Sartorius, I might treat it again a little bit on the stretch. So I might actually put it in the stretch position like this.
The
They come in
Sartorius
here.
makes a lap.
And we're going to go from the superior iliac spine, come like this and treat it right like this all the way over to here.
Yeah.
Just like that.
So that's how you stretch it. How would you shorten it?
This way.
Yep. Makes
So
a
like-
lap. That's what it makes a lap like that.
Oh, yes.
Okay?
Yeah, so then I often treat it like this too.
And so then how would you test it, do you guys think? You would put it in the fibers are straight now. This is the sartorius right here. It is in a straight line right now in this position. Normally when the leg's straight, it's twisted. But here it's in a straight line. So it's treating it, boom, just like that. And so that's just how we test it too.
That's a great spot.
Yeah, the Pezan Serene is going to be a good spot for a lot of people with knee problems.
Okay.
And here's how we would test it. We'd put it right back in that position. So make sure the fibers are straight. So here they are straight, just like that. And I'd have you hold it in this position. And I'm going to pull the whole thing down like this. Push that way into my hands. And I'm going to add 1, 2, 3, 4. Okay. And I'd say it's pretty good. Pretty good.
It wasn't too
Okay.
bad. Very good.
Yay!
Yay. Okay, let's roll off and let's have you stand up. Great. Super. Look at that girl go. Okay. Okay, so tell us how you're feeling.
Let's see.
She's going to do a nice test. So that's good. So now you're coming much
Lower.
closer. That's only
Great.
about 2 inches from the floor. So we
Little
went from
better.
about 6 to
Sure.
2. Great, great.
Great.
Want to see how you're doing with her squat test?
Flat test.
Okay, here we go.
And she thought it couldn't get better.
There we go. It's 15 there. So that's good. All right. So, how's the knees feeling?
A little better, yeah.
Good, good.
Sure.
So you were saying you had pain on the inside of the knee.
Mm-hmm.
How's that feel?
That still hurts, but the rest feels a little better.
Okay, the back is feeling a little better.
Back
How
feels
about the front?
better.
How's the front
The
feel?
quad feels a little better.
Good.
Below the knee is a little better.
Okay, great.
It's just still right here. But
Okay. Also, a little bit more needs to be done there. Okay.
Okay.
Yeah, I think
All right.
you know what was the one there was that gracilis. So why don't you go
Gracilis.
ahead and continue to treat the gracilis on your own?
Mhm.
Okay, so what do you, Kirk? Let's see what you think. Do you think that you can do the kneeling a little bit better?
I think so, yeah.
Okay, let's give it a try.
Yeah.
Okay, and you could see if you can sit back just a little better.
Yeah.
Okay, so working? Can you imagine working then?
Yeah. Yeah.
Yes.
That'd be easier to do.
Okay, good. All right.
Getting there.
Good, we get a few things.